I'd like to invite Dr. Professor G.C. Khilani sir to chair the session. And one more lecture, actually it is some jumbling. So the next lecture will be on the one remaining lecture from shock. So it is extracorporeal support in the shock. What are the options and the indication by Dr. Sricharan Goda.
Good afternoon, good afternoon, everybody. Today, I thank the organizing team of Critic to actually given me an opportunity to speak about the extracorporeal supports in shock. What are the options and indications? So, after the results of the shock 2 trial, which has said that the IABP does not have a mortality benefit in the uh, in patients who are having cardiogenic shock, the next best thing that everybody was actually looking forward to is the extracorporeal life support. So as expected, the extracorporeal life support was thought to be had to have a very good role in the cardiogenic shock, most commonly which is caused by the acute myocardial infarction, myocarditis, cardiac arrest, post heart transplants, post cardiotomy, where we have enough evidence saying that this early or timely institution of ECLS is going to help save lives in these patients. However, there are certain extended indications which are coming nowadays, like acute pulmonary thromboembolisms, postpartum cardiomyopathies, sepsis, drug intoxications, and in some cases of arrhythmic storms. So to come back, what is the when do we actually have to initiate ECLS in any of these patients? As we have already known about these stages of cardiogenic shock, we see that most of these patients, it is the stage D and the stage E, the decompensated and the extremist stages of this classifications of cardiogenic shock. Do we have any meaningful effect of extracorporeal life support organizations? Sorry, extracorporeal life support systems. So these extracorporeal life support systems, before we institute them, it is better that if we actually think about whether or not this system is going to help us. So there are certain scoring systems which help us in identifying whether or not extracorporeal life support systems are going to help, or what is the predicted mortality rate of these patients if a timely ECLS is instituted. So this can be given by some of the scores called the SAVE scores, encourage scores, predict scores, etc. So majority of this for cardiogenic shock patients, the also recommends scoring system called the SAVE score, survival after arteriovenous ECMO. So this has taken certain groups into consideration, where there is an acute cardiogenic shock diagnosis. So what is the cause of cardiogenic shock, age of the patient, weight, pre-ECMO organ failures, duration of initiation or duration of intubation before initiation of an ECMO. What are the ventilatory parameters like the peak inspiratory pressures? Do we have a pre-ECMO cardiac arrest, diastolic pressures, bicarbonates, etc. And based on these scores, they have actually risk stratified these patients into 5 classes, and each class has its own mortality rate. The known contraindications as per also comes to like cardiac recovery unlikely, or if there is no indication, or if there is no chance that the patient might go to a bridge to transplant for a cardiac transplant, or bridge to destination therapy with an LVSS device, or if there is a poor life expectancy, severe aortic valve regurgitation, severe vascular diseases, aortic dissections, neurological impairments, and liver cirrhosis. So given these multi-organ stages, we can actually assume that these patients are not going to benefit from an ECLS support, or the long-term benefits of ECLS support is significantly questionable in these patients, and hence ECLS is probably contraindicated. However, we can actually say with reasonable confidence saying that they even in this indications, except for aortic dissections and severe AR, or if the patient is having acute intracranial hemorrhage, none of these are absolute contraindications. We can still apply ECLS in these patients and see whether there is an improvement in the shock. Now, if we are actually discussing about the institution of ECLS in patients with cardiogenic shock, what is the evidence we have? We have two major trials which actually compared ECLS with conservative therapy, and there is the trial which compared with microaxial flow pumps. So this is actually called the ECLS shock trial, which has randomized 417 patients. So in the 417 patients, the group of patients have actually were taken into early extracorporeal life support therapy, as well as the other control group was actually with conservative management. That is the maximal medical therapy which we have known. But we have to understand here that most of these patients, if you actually see that 49.8% in ECLS group as well as 53.4% in the control group were SCI C patients. So this is a relatively long trial which has taken 10 years for recruitment, and we can actually see that there is a change in the modality of classification of cardiogenic shock as well as the uh, treatment of a cardiogenic shock based on this classification. So majority of these patients comes under SCI C, which is a classical cardiogenic shock who might or might not require uh, ECLS implantation. So what is actually interesting in this particular trial is that if you can see in the ECLS therapy, obviously 91.9% has received ECLS, whereas 12.5% of the control group also have received bailout ECLS. And then in the other mechanical supports which are instituted in these patients, none of them in ECMO group have received any mechanical circulatory devices. However, there are 15.4%, 28 out of 182 patients received other mechanical circulatory support other than ECLS, which actually calls into question the integrity of the control group for us to actually make any meaningful recommendation. However, based on this and based on the intention to treat analysis which they have done, they have said that this particular early institution of an ECLS in a patient with cardiogenic shock, infarct related cardiogenic shock to be very specific, did not actually confer any mortality benefit to these patients. So the similar trial is from Czech Republic. It's called the ECMO CS trial. The ECMO CS trial already also has relatively compared similar scenarios in which they have included a wide range of cardiogenic shock patients, among which acute myocardial infarction was only one of the parameters, and they have also included patients with dilated cardiomyopathies and also myocarditis kind of things. In these patients, they have actually given a very complex complicated endpoint. So this is not just death, or it is a composite endpoint which is taking into consideration death or escalation into other mechanical circulatory support or escalation to an LVAD therapy or a heart transplant. So this composite endpoint was tested between ECMO versus the conservative group, which did not confer any mortality benefit. However, we can actually see this is a study which is more pragmatic in its design because this included only the SCI D and SCI E class categories. That is number one. And we have to also remember this actually compared the early ECMO versus early conservative therapy with bailout ECMO later on. So this is not just an ECMO versus a non-ECMO kind of randomization which we are seeing here. It's a but early ECMO versus bailout ECMO. So this particular study has to be understood in this particular context. So it included a wide range of cardiogenic shock patients. So we have, as I was discussing, 39% of patients in the control arm received veno arterial ECMOs in these patients. So they might not have received VA ECMO during the initial timeline of early ECMO. However, they have received in the later stages. But there is one most important or interesting point which I find in this ECMO CS trial is that there is no difference in hemodynamic or vasopressor requirements at the time of randomization of the study itself. So what defines an early ECMO or what defines not an early ECMO is what we have to understand, because both this test and the control are reasonably sick at the start. So what did they actually, how did they define it as an early ECMO? Did they immediately institute the patient on an ECMO whenever there is a very set criteria that are met, or what is the conservative management of SCI D and D patients is what we need to understand in this particular study. So there is another study called the danger shock trial. So this has actually compared a microaxial flow pump with a standard care to that of a standard care alone in STEMI related cardiogenic shock. So they have included STEMI or STEMI equivalents, and then they have actually done this study. It's a reasonably big study. However, we have to understand what is the microaxial flow pump that they have used is the impeller. Then one major issue from this particular study is that they have comfortably excluded patients who are having RV dysfunction. So because Impella, as we know, does not support patients with RV dysfunction unless we are actually using an Impella RP for that. So they have used Impella CP for most of these patients, and some of the patients received Impella 5.0. So both of these supports are only for left ventricular dysfunction. So they have ignored or they have excluded the RV dysfunction and biventricular dysfunctions in these patients. They have taken SKY, C, D, and E as the ECLS shock trial, and we have seen that the 55.9% in the standard care and 55.1% in the control group were actually having a comes under SKY C classifications, which is probably not so sick because they have actually included patients whose ejection fraction, among the criteria for inclusion, one of the criteria is that the ejection fraction should be less than 45%, but with higher lactates. So ejection fraction of 45% with higher lactates is relatively a liberal criteria for institution of a mechanical circulatory support. But we have to also understand that 15.6% in microaxial flow pump group and 21% in standard group required additional mechanical circulatory support. So among the total amount of secondary MCS which were deployed in the danger shock trial, 80% is veno arterial ECMO. So we have actually seen 3 trials. So to actually compare these three trials, so the ECLS shock trial used VA ECMO. It used only SKY DND, but it has the post cardiac arrest patients were almost like 11%, and they have ignored patients or they have excluded patients who have comatose after cardiac arrest because the cause of death in these patients is most likely cerebral injury rather than a cardiogenic shock itself. We can also see that this post cardiac arrest patients is 78% in the ECLS shock trial. So which if we remember the SAVE score we were discussing, that is associated with significantly poorer outcomes to begin with. The mechanical ventilation strategies and unloading strategies are not actually defined. However, we can actually see in the rescue MCS, 39% rescue MCS in control group, 13% with VA ECMO and 13% with rescue MFP in the ECLS group in the ECLS shock trial, whereas in rescue VA ECMO was deployed in 13% of this patient. So none of these trials were actually probably I should say pure enough to identify whether or not VA ECMO is going to help in cardiogenic shock patients or not. But given these 3 trials, given the ECLS shock trial and the ECMO CS trial, which did not confer any mortality benefit, versus the danger shock trial, which actually had a statistically significant mortality benefit at the end of 6 months, this begs the question. This begs the obvious question that is mechanical circulatory support in cardiogenic shock. So are we actually going towards microaxial flow pumps, and is VA ECMO probably outdated? This particular editorial gives a very clear-cut answer for that. So their comment is that they did not compare the early use of MCS versus medical therapy alone. As I was discussing before, they compared medical therapy assisted by MCS at physician's discretion to that of early institution of ECMO supports. So we have to understand that among all these trials, one major caveat is that they have used ECMO as a bailout when any patient in the control group has has met predefined criteria or has met severe decompensated shock. So even after instituting a conservative management in a control group, that is probably in SKY CD categories, if the patient is still deteriorating, so by definition SKY D, they have instituted a VA ECMO in these patients. So did that actually do justice to the trial per se is one thing which we have to answer. Then there is a very per protocol initiation of the VA ECMO support. So whenever there are certain well-defined criteria which were which if met, they were initially instituted on a VA ECMO support, which in clinical practice there are various kinds of mechanical circulatory support devices which are available, and everybody was universally opted for a VA ECMO in these particular studies because of the study protocol. So as I was telling you before, if 77% they are included patients, 77% of them are post cardiac arrest patients, they obviously did not consider the probability of survival of these using these scores like SAVE score or the encourage score. And there is as we have seen, there is significant crossover or rescue initiation of ECMO to other MCS devices. Given this thing, the authors conclude that it does not, even though the current evidence does not support the use of ECMO in all cardiogenic shock patients, there is still a very definite role which if instituted at an appropriate time. What is the appropriate time, which we have to probably understand with future trials, and these we can actually see that the way ECMO has been used as a bailout device, there is still a role of veno-arterial ECMO or extracorporeal life support in the management of cardiogenic shock. So which was probably graphically represented it quite nicely in this particular paper from Circulation, where when are we opening the parachute of extracorporeal life support? Is it too early? Is it right time? Or is it too late? So probably Sky Shock C, if you only consider lactate less than 4 as the criteria for shock, if the patient is on less than, maybe less than 2 vasopressors, we are instituting them on ECLS is probably too early, and we are unnecessarily subjecting them to complications of ECLS rather than the advantages of that. So if the patient is in Sky Shock D or E, increasing lactate levels progressively, which are being measured every 4th hourly, increasing vasopressor supports, or if the patient has a cardiac arrest. When the patient has a cardiac arrest, there is no question that this patient is going to require a bailout ECLS supports. Or if the patient has received CPR for more than 1 hour, greater than lactates greater than 18, probably we have the ship has sailed. So in patients for cardiogenic shock, where we can define with stroke volume less than 30, LVOT VTI less than 10, if it is acute myocardial infarction, there is cardiac arrest, always go for a VA ECMO. If it is non-cardiac arrest or if it is non-acute AMI or acute AMI, if there is isolated LV failure, probably we'll consider microaxial flow pumps. So I'll skip this, and one of the burning questions we have is whether ECMO is helpful in septic shock. So there has been a significant discussion on the various two kinds of shock that can happen in an ECMO, majority being the vasodilatory shock and the other thing is the septic heart. So we have actually have a meta-analysis of various studies of 468 patients and who are instituted on VA ECMO for the support of septic shock, which said that if the VA ECMO, if the LVEF is less than 20%, that if septic cardiomyopathy is the cause, then that is 62% of survival is reported. Whereas if the LV ejection fraction is greater than 35%, implying that if we are dealing with more of vasoplegic shock, then the survival is around 32% only. So if the adult patient, because the most common cause of common shock in adult septic patient is vasodilatory, you would not really go for a veno-arterial ECMO. But whereas in a newborn or in a child where there is a very good chance of patient developing left ventricular dysfunction as a secondary component of septic shock, we can probably go for a VA ECMO. Coming to notes on poisoning, CHA recommends VA ECMO when there is a severe cardiogenic shock or a cardiac arrest secondary to drug intoxication or poisoning, but these are not well defined. The level of evidence is low evidence with or expert opinion at best, with the recommended category of 2A or 2B. So if there is a life-threatening poisoning, and if we are seeing a patient whether has developed a cardiogenic shock or a severe respiratory failure, not amenable to conservative therapy in spite of adequate antidotes, ECMO can be used as a bailout in these cases. So to conclude my talk, I would say that VA ECMO, I believe that still has a role in the management of cardiogenic shock if intervened at an optimal time. We need to define what an optimal time is, and we need to define at what stage of shock should we intervene. The design of randomized control trials and ethical issues. So if any procedure is used as a bailout procedure or if it's being used as a absolutely life-saving procedure, probably designing randomized control trials is difficult, and the putting patients in the control group, depriving them of the said life-saving procedure would be unethical. So we would be expecting a lot of crossovers in all the future studies also. I wouldn't really think that there will be a randomized control trial without a crossover study. VA ECMO has a role in management of septic shock associated with cardiomyopathies. It does not help in distributive shock, and it is recommended, albeit with a low quality of evidence in poisoning. Thank you.